Dr. David Bull's Sunday Surgery.
Well, Dr. Renee and I had this conversation during the week and we thought, what should we talk about that would be interesting and informative and that affects most people? And then we suddenly started talking about the feet. And that's, I think, because we don't talk enough about the structure, the function, the anatomy of the feet, and how many medical complaints are related... When they go wrong, how many medical complaints are related to the feet?
Mm-hmm. Yes,
Agreed.
absolutely. And it was one that affected me, which is how I knew about this.
Which we will reveal in a minute. Yeah. So we've invited on a lovely chap called Ron McCulloch, who is a consultant, a podiatric surgeon. Good morning to you.
Good morning.
Really good to talk to you. Thanks ever so much for joining us in your rather splendid scrubs there this morning. So can you start by talking us through the feet? Because I think many people think of the feet as rather these passive objects. In fact, it couldn't be further from the truth, could it? In terms of the muscles, the number of bones that we've got, the innervation, the number of nerves, blood vessels and so on, and also the function of the feet and the way that we walk and our gait.
Yes, indeed. Well, you know, it is a very complex structure. If you think about the knee, it's basically two joints. The foot has 33 joints, 26 bones, lots of tendons, ligaments, of course. And so it is a very complex structure. And this is actually one of the areas I've always been very interested in. And whilst I perform surgery, I also like the biomechanics and the gait analysis side of things and really trying to understand how the foot works. So it is a very complex structure that takes a bit of understanding.
And we sort of... ignore them, don't we, as people? We think they sit on the end of our legs, they're expected to function, and when they don't, we're upset when that happens.
Yeah, we take them for granted. I always remember patients often say, oh, well, my feet hurt, everything hurts, and it is something people ignore, and especially when it comes to shoes and things like that. As with other areas of medicine, I guess sometimes you take things for granted, but yes, when they go wrong, then you know about it because we have to walk, and it's there to remind you all the time.
And is it fair to say that most people don't have nice feet?
I think that's probably a fairly subjective comment. I don't
know anyone that's got nice feet.
My feet are lovely.
Your feet aren't nice.
Well, I obviously don't see the nicest of feet in my job, but they are out there for sure.
Okay, so what's the most common thing that you see when people present to you?
Well, probably at this stage, because I specialise in it, a condition called Morton's Neuroma, which is a trapped nerve in the foot that, I specialise in. OK, so let's talk about Morton's Neuroma. And there's a reason for this, isn't there, Dr. Renee? Why are we interested in this?
So Morton's Neuroma was something I suffered with for about 15 years in both of my feet. I went through all of the conservative measures of nice, wide footwear.
You knew what it was?
I knew what it was. I went and had it scanned when I was working in the hospital. Right. And I then had, over several years, several steroid injections, which on my right foot worked and it went away and it never came back. But on my left foot, I was left with constant pain. And you know I'm partial to a pair of stilettos.
I know.
And I got to the point where I couldn't wear a pair of stilettos for more than an hour because the pain was too much. And then the pain would continue when I took my shoe off because then the bones spread and it really started to hurt. And I'll leave Ron to explain exactly what it is. But eventually, in desperation, I didn't want to have surgery because I didn't want to risk my nerve being cut and the downtime. I found Ron was doing a novel treatment which was less invasive, and I thought, why not, let's give it a go. And I did that about 5 months ago.
OK, so Ron, tell us about Morton's Neuroma.
OK, well, fundamentally, it's a thickening of a nerve. It's a bit of a misnomer. A lot of things in medicine are called things, and later on we found out what they really are, and the term is not quite correct. So it's the same with Morton's Neuroma, because it suggests that it's a tumour of nerves, but what it actually is a nerve that's got fibrous tissue around it as a protective mechanism. Just as we get hard skin, if we, stress our feet too much, the nerves will also protect themselves and build up extra fibrous tissue. And a lot of people have that. Up to a third of people will have some thickening of their nerves, and they may not have pain. But when it does get to a certain size and a certain level of irritation, it's a big problem. It can be extremely painful.
OK, so what is the pain like that people would experience?
Basically, it does present in different ways. Sometimes people get mainly pain on the ball of their foot, and sometimes they get that sharp pain running into the toes. It's a bit like sciatica. Some people get back pain with sciatica, and some people it runs right down the leg. It's exactly the same with Morton's Neuroma. It can be local, but most of the time it feels like there's a rolled up sock or a lump under the foot, and you can get this sharp radiating pain into the toes. And the key thing is it doesn't... So if you're walking and you feel it, you can rub your foot a bit, and it will often feel a bit better, and then you can walk a bit further again. If you have a bruise or another condition, stress fracture or something like that, that's not going to happen. The classic feature is this intermittent pain.
And causes?
For the the direct, easy answer to that is excessive pressure and friction on the nerve.
Stilettos.
It doesn't help, but some people will get away with stilettos more than others, and it just depends on the structure of the foot.
Right.
You know, if you've got a very wide foot, you're going to struggle in stilettos. If you've got a nice thin foot with short toes, you're going to get away with more. There's a very short and a very long answer to that, and we specialize in all the kind of biomechanical analysis to find out why it happens so we can deal with it.
So Ron does see, I think I'm right in remembering this, Ron, lots of cyclists and runners.
How interesting.
And of course I like running, and
yes.
I like wearing stilettos, and I have a very wide foot.
You don't wear stilettos whilst running, though?
Sometimes, but most of the time trainers.
Fine. So then, when Renee saw you, so what would you go through? Can you talk us through your diagnostic pathway and how you would then go about treating her?
Yeah, so I think, you know, they do say 80% of a diagnosis is in the history, and I think that's often as soon as people start talking about it, you think, this is very likely to be a neuroma. There's then a classic test you can do called Mulder's sign, or a pinch test, which causes a clicking action in the toe. And if that's positive, then you have a look at the ultrasound. I specialize in diagnostic ultrasound, so I would do that to clinch the diagnosis. But you've got to be a little bit careful because the ultrasound can be positive, but as I say, it may be a silent, non-symptomatic neuroma. So everything has to link together. Then after diagnosing the problem, we try and deal with it conservatively, of course. You try to avoid anything invasive if possible. So we would do some analysis, find out perhaps what shoes might be ideal, what type of padding, what type of socks, what type of activity adjustments might help. You mentioned road cycling. So just one simple example, road cyclists get this a lot. You can get a special adaptation to the cleat that brings the foot forward so you don't have all that pressure, and that can just solve the problem.
Oh, so that is brilliant. That is brilliant, because you're right, of course, all your weight is going through the cleat when you clip yourself into your bike.
Yeah, exactly. Yeah.
So, Ron, would you be prepared to stay over the break, because we're having so many messages from people who want some advice from you?
Yeah, sure, of course.
Fantastic. Ron, stay where you are. We'll take a break. We'll be back after this.
Is talk.
Welcome back. So we're in the middle of a conversation with Ron McCulloch. We're talking about Morton's neuroma, which he's explained beautifully. Dr. Renee had a Morton's neuroma. Now, Ron, can we go back? So basically, you diagnosed Renee with a Morton's neuroma. What did you do to resolve it? Because she was adamant she didn't want surgery.
Yeah, so, I mean, obviously, various things had already been tried, like steroids and other things. So, therefore, we were limited in our options. And I know that Renee had a specific interest, and I found out about cryosurgery, which is a condition that I specialize in. I do open surgery, which is the more traditional way of doing it. But I now reserve open surgery for neuromas, which are exceptionally large or where everything else has failed to work. But I try and perform cryosurgery. And
can you explain that for people?
Yeah, so cryosurgery is used in various areas of medicine. It's been used for treating cardiac arrhythmias, and it's now being used more and more for treating tumors. And it was on that basis that I became interested, because I thought, well, if it will work for that, it should work for, you know, a thicker nerve, which is just a form of growth and thickening. So basically, I went to the States and I learned the technique, and it basically involves, I've been doing it for about 13 years now. It basically involves placing a needle into the foot, which is a bit wider than perhaps an average needle, but still fairly narrow. It then, under ultrasound guidance, it touches the neuroma. You can clearly see it. You just go a little bit behind it. Then I press a pedal, and basically a gas passes through that needle, and it forms an ice ball. And that ice ball goes to about minus 80 degrees, and it begins to freeze and break down the nerve. And you do that several times during the same session, being very careful to target the nerve in the correct manner. And then as a result, I think two things happen. It breaks down, but it also desensitizes the nerves so that you just don't feel the pain. But there's lots of benefits. I mean, it's a procedure that's done, you know, outpatient basis. You have it done, you can literally go back to work the next day, as opposed to having to have 2 weeks basically on your back resting, not being able to do anything. The incision is 1 or 2 millimeters rather than, you know, 3-4 centimeters. So it has a lot of benefits. And the key thing for me, I mean, even though my open surgeries were successful, you know, even in the best surgeon's hands, you're going to get somewhere about a 5-6% complication rate from open. And you can get something called stump neuroma with open surgery and other complications, and they can be highly distressing. And obviously, if you do 100 procedures and 95 are fine, but 5 patients are unhappy, you only think about the 5 patients. So I was always looking for something that would give me even higher success rates or at least lower complication rates, and that's what cryosurgery does. I've done thousands of cryosurgeries, and it's just a highly it's a very safe procedure. You're very unlikely to have issues with it. Of course, it's always possible. We have to counsel patients about risks, but on the whole, you know, other than a few mild infections, I've had very few issues with cryosurgery. So it's my preferred option because it helps me to sleep well at night, because I have very few worries about my patients.
And what's the result like?
Right, it has worked. Ron knows this, but it did take about 3 months to fully, and I was very good. I didn't run in that time. Ron suggested I didn't, which I do like to do. And
it's amazing she listened to you.
I did. I'm a good patient, actually. I told Ron I was a good patient. And actually now I'm wearing my heels as often as I want. I don't have to worry about it, and everything's good. But it did take about 3 to 4 months to get there.
Fantastic. Ron, would you take a call, please? This is one of our friends, a friend of the station. Spike is in Pembrokeshire. Good morning to you, Spike.
Morning, David.
Morning, Spike.
So what's your question for Ron?
I was the same problem as Dr. Renee. I developed a Mortons Neuroma after ankle fusion I had on my left ankle, and I developed a neuroma in my right foot because I was predominantly putting, obviously, my weight on there. And the surgeon that did my ankle suggested, well, I had 2 injections first, which were unsuccessful. And then he said to do the incision, you know, and had the nerve removed 3 years ago. And now I'm in as much pain as I was previously. And having spoke to the surgeon, he said there is the condition which you just mentioned, stump neuroma, which I presume now I've developed. And I'm back to square one I was before. And it's forced me into early retirement. And I'm now, because I was standing all day in my previous position, in a previous job, and then now, you know, and I'm sort of wit's end to think, you know, what to do. The surgeon has said if I open the scar up again, it's probably going to cause you more problems. So my question is, you know, where do I go with a stump neuroma?
Ron.
Yeah, I mean, there's a few ways to answer that. First of all, you know, you do need to look at the biomechanics. If you're favouring that other foot, I would want to know exactly how you're walking, because an ankle fusion has a profound effect on your gait, and it will cause a lot of overload and changes in your gait, and we may be able to modify your gait in such a way as to help by you having some advanced gait analysis at our facility. That's important, because if you have huge amounts of irritation on the area continuously, that's not going to help your recovery. But the other thing I would just want to do is scan you just to make sure that there aren't other neuromas. You can easily have another neuroma, and it's not it's not uncommon to be in a situation where patients come in, they've been diagnosed with a neuroma, and they've had all these treatments, and then actually it's the one next to it that's been the bigger problem. And so I'm not saying that it could well be just a stump neuroma, but these are all things we have to explore. And then finally, if it's a stump neuroma, the way that I manage those, and it is one of the greatest concerns with Morton's neuroma, is I do diagnostic injections. I mean, you can do all the scans in the world, but you can't be 100% sure about whether that is your problem unless you do something like a diagnostic injection. So if I drop a tiny bit of local anesthetic right next to where we think that stump is, and you go and walk and you have no pain, then we know we've hit the target. Unfortunately, it's going to come back. As soon as the anesthetic wears off, in a few hours, it will come back. But I know exactly where to place my cryoprobe the next time. And there's also something called radio frequency, which I also do, which is basically very technically similar to cryosurgery, but it's actually a hot needle, and it actually can burn through the nerve. So these are all other options. And sometimes with, and it can get more complex, sometimes with stump neuroma and an abnormal neurological response, there are other treatments I use, like something called radio frequency, pulsed radio frequency, which is not a heat modulation. It's actually something that you use to target the nerve and change the behavior of the nerve without actually destroying it. So it's about understanding your mechanics, dealing with the cause, coming up with some solutions there, and then making sure that's been addressed. And then, yes, we have these different treatment options to manage you. So don't give up hope yet.
There you go, Spike. Don't give up hope. Ron, thanks ever so much for your time.
Ron.
That was today's Sunday Surgery.